Hello, everyone. My name is Matthew Maynard. I work with Hemophilia Ontario, and it's my pleasure to introduce and be part of this webinar this evening with Dr. Alfonso Iorio. He'll be talking about individualized treatment planning, and Dr. Iorio is a medical director of the Hamilton and Niagara Hemophilia Program based at McMaster University and McMaster Medical Center. With that introduction, Dr. Iorio, I'll pass the microphone to you.
Thank you very much, and good evening, everyone. I hope I've been able to reconnect me properly. Can I, do I get through clearly?
Yeah, hearing you well.
Good. So let me see if I'm successful also in sharing my screen. Can you see the screen already?
No, not seeing it yet.
So let's see. What about now? No. So let's see what the problem is. So maybe I'll stop sharing the webcam and then so okay, now should be okay. Okay. Sorry for the glitch. So individualized treatment is something we very often discuss about these days, and my goal for this evening would be to have a broad discussion about what individualized treatment means and which tools we have available for this goal, and what's happening in Canada, at least for what I'm aware of. If there is anything I'm unable to spell clearly, or if there is any need for clarification, feel free to ask on the go. I'll try also to save time in the end for question and more general comments. Now, as a quick introduction on top of what have been said already, you'll find most of the project I'm going to refer to and this slide set as well on the McMaster Hemophilia Research Group website, which collects all what we do in Hamilton in the field of bleeding disorders, our publication, but also the project we run, the collaboration we have. We don't have completed yet the clinical page, but for all what is the research part, you'll find details here. And this is also an excuse for me to point out that we put clinical care as the center of our activity, but we like to think that we use the clinical practice and any detail of our experience to try to learn how to do our job better, and we also put a lot of effort into sharing what we learn. And this is one of the reasons we are here this evening, because we'd like to get feedback and provide our knowledge about individualized treatment. Now, let's move directly into what are the components that require to make treatment individualized. So it's like if you think of buying a suit or buying a dress, you can go in a shop and pick one out of those ready off the shelf, and very likely it will fit you, but not as nicely and not as precisely as if you take the time going to a master tailor, having him or her measuring you in the critical point, and then creating a suit or a dress directly for you, because we are all different. Okay, we all have common characteristics. We have 2 legs and 2 arms, and overall the size of the human beings varies a little, but there's a lot of individual variability, and this variability in hemophilia is correlated with important outcomes. If you look at this plot here on the left, I'm sure you have come across this one already. On the vertical axis, you have the number of bleeds. Now it goes from 0 to 6, but you can think from 0 to infinite. The higher you are on this scale, the more bleed you have. What you have instead on the x-axis is the factor level concentration. And you would expect that if your factor level is close to 0, you will have more bleeds. When your factor level gets to 1, we say, well, 1, you should be not bleeding anymore. You are not anymore a severe patient. You see that instead, there are still many bleeds. And yes, their number goes down as the concentration goes up, but still at 5%, you may have 1 or 2 bleeds per year. Now, you may start getting upset with me and saying, well, we all know what you are saying. We all know that no matter how much factor we take, we'll still continue to have some bleeds. Yes, unless you insist and you go on and up. And at about 12%, the rate of bleeding, spontaneous bleeding, gets very, very low. So there is some correlation between the baseline level of factor 8 or 9 that the patient has in blood and the number of bleed he will get. Now, this plot here correlates the spontaneous level of factor in the blood with the number of bleeds. The one instead here on the right correlates 2 dimensions that are somehow the product of the baseline and the factor that is received at treatment. So on the X scale, this time you have the time spent with the concentration below 1%. So if you think of a patient that has no factor around and get recurrent infusion of factor, he will be at many points down this scale on the left. He can be up here when he doesn't get any factor infused, or immediately after an infusion, he will be down here at 20. So it's sort of the patient moving down the scale, depending how much time has elapsed since the infusion of factor. Now, if we measure the amount of time spent below this line on this axis, and we look at the probability of bleeding, where up here we have no bleed at all. So this time being high is good, being low is bad. So if you don't spend any time below 1%, you are very good, you don't bleed. If you spend some time, say 50% of time below 1, you are going down this line and you bleed more and more and more. And this line up here is for adults, this one down here is for kids. We start learning that the difference is also in the age. So one component of tailoring is that the amount of concentrate, the amount of factor in the blood is correlated to bleeding, and the time we spend at concentration where we can measure factor 8 reduce our tendency to bleed. I stop for a second. Can you follow? I assume you do. And I'll continue. But if you don't, please let me know. There's no point for me to talk to myself. Now, let's see age and previous bleeds. So the tendency to bleed decreases with age. You bleed more when you are a kid And then again, here you have no bleed up here, bleeds down here. Let's consider high risk of bleeding, 1, low risk of bleeding, 0. And here is age. The more you go on with life, there are usually only drawbacks in growing old, but for hemophilia, the older you are, the less you bleed. It's a common experience. And the other concept is the more you bleed, the more you had bled in the past, the more you will tend to bleed. So the red line is those who had more than 10 spontaneous bleeds per year. They have a very high chance of bleeding again. And yes, that decreases over time, but still is much higher than the chance of bleeding of those having few bleeds. So another component that is important to take into account when we think of we are all different, we need to give everyone their own treatment, is that we might require less and less treatment as we grow old, and we may require more treatment if we bleed more. Not only if we bleed more now, but we can predict we will get more need for treatment if we have bled a lot in the past. Another important concept is that not every bleed is self-evident. This is a plot from the Menko-Johnson study, the study comparing intense prophylaxis toward on-demand treatment. This was a study that created a lot of discussion. Many called this study unethical, saying that was not appropriate to treat kids on demand in US a few years back. But this was meant to finally confirm and take away any doubt that prophylaxis was able to prevent all bleeds. And indeed, it was able to prevent all bleeds that were self-reported by patient. But when the patient did their MRI at the end of the study, some of them, they had never reported a bleed and still had some signs of blood in their joint. So sometimes you need to rely in deciding how intensively you want to treat a patient, also on assessment, on images, on diagnostics that needs to be done to ensure that we target treatment to the need of a patient. If the patient doesn't report bleeds and doesn't have any sign of bleeding, he may be treated less intensively than those not having clinical bleed, but having signs of degeneration in their joint. And I could continue. Target joints are another patient characteristics that may require a more intense treatment. Now, you have to imagine that all of these acts all together. This picture is intentionally complicated, and I describe on this left side a situation of low bleed. This is a very quiet situation where the patient, first of all, is compliant with prescription. This is a nice pre-teenager kid with a very, very caring mother, and he gets every single injection that is prescribed. And those injections have been phased in their sequence and in their amount by a good doctor who managed to get, yes, the factor going up and down because we have no other option until new therapy will appear, but in a way that the risk of bleeding is always low. And this patient gets all the infusion he wants, and he doesn't get below the critical threshold anytime. He is at very low risk of bleed. If instead you think of, okay, now we move to, for example, a vacation period, and we may skip an infusion here and there, and then the concentration changes, and also we are on vacation, we are a bit less careful, we do activities we don't usually do, then you see that the risk of bleed increases, and you get to much higher risk than you would expect in a standard situation. So not only we are all different, but we can live in different situations, and the need for treatment can vary depending if we are in the ideal situation or if we go down into real life. Now, when I think of tailored prophylaxis, I put all of these together and I see different contribution to be able to create for each one the treatment that fits them better. Something is your tendency to bleed, something is the level of activity you intend to reach. One might be not really interested in sports, or instead one could have been had a easy, quiet life, and then he decide to become a father and he start running after kids. That's not physical activity in a strict sense, but is very, very demanding. And being in a physical active situation or in a quiet office style situation like the one I'm in now can require a different treatment. So one other aspect is how every patient handle their own factor. And this is where there has been some confusion in the past, and personalized prophylaxis has been conceived as using pharmacokinetics to identify the best dose and the best frequency. Pharmacokinetic helps. I will try to convince you over the next few minutes, but it's not everything you need. You need to know your patient very well. You need to know the history of your patient, the test that your patient has done, the status of their joint, and also what the goal, the life goal for that patient are. You need all of these information together to be able to build the ideal treatment regimen. And I'll show you going forward how at McMaster we are trying to facilitate collection of all of these information for every single patient in Canada. First of all, I'll try to make pharmacokinetics easy to understand for you. I want you to take a few minutes to understand why it's important to estimate the profile, the shape of the curve of the factor concentration over time in each patient. So what we have here on the epsilon axis, we have the factor level. So here is say 100%, down here is 0%. This is the amount of factor one has. Here on the X, you have the time in days. So 0 is the moment of the infusion. Then after 1 day, 2 days, 3 days, 4 days. So assume you are the factor, the patient depicted in green. You get a shot of factor, and your factor goes down very quickly. After a few hours, is already, say, 25% of what it was initially. Then it slows down the fall, and then it's flattened up, and it stays around for almost a week. So you inject it, goes down, then slows, and stays around for very, very long. The patient in yellow goes down more slowly, so after half a day is much higher than the other one, is slow, and it stays on this phase of the curve for longer, and then it starts dropping much faster than the green one. You can think of green and yellow as two different patients, or you can think as green and yellow, two different concentrate in the same patient. You may be on this curve with, say, a plasma-derived factor 9, and you can be on the green with a long-acting factor 9 or factor 8, whatever you want. It doesn't really matter if these are two patients or two concentrates for the same patient. What it matters is that if we consider, again, the situation of a very non-active patient, and this patient bleeds when he gets to this low concentration. In this case, the patient in yellow gets to the threshold for bleeding earlier. He gets here at 5 days after the injection. Still a good interval, still 5 days without risk of bleeding, but he gets to the threshold in 5 days. The one in green gets to the threshold in about 7 days. So if the patient is a sedentary one, the factor in green could be better. Or if these two patients are sharing the same lifestyle, the patient in yellow will need to reinfuse himself at 5 days. The patient in green can infuse himself at 7. Okay, is then green better? Well, it depends. Because if you now consider instead an active patient that is working on his own feet and is all the time delivering boxes, he will bleed very likely at a higher concentration. In this case, the patient in green or the patient receiving the concentrate in green will get to the critical concentration much earlier, here, not even a full day. The patient in yellow, yes, not anymore 5 days, but 3 days. So for an active patient, in this case, the yellow profile is more favorable. This is why it's important to study the variation of the concentration of factor over time, because once I know for each of my patients how the shape is, I can give them the best advice as to avoid bleeding, and we can together identify, depending on what their goal is, when to re-inject, how much to inject, to be sure that we stay above the threshold. Now, if you expand and you think of many patients, and they all start here and they all end here, they can take many different paths to go there. And if you consider again that this dashed red line is the threshold for bleeding, the patient that follows this dash red will bleed here, and the one following the thick blue will bleed here. Problem is, how do I identify which one of this curve is the one describing each of my patients better? Well, if I have a lot of time and I have patients that are very patient, I can draw a lot of samples over time, and when I'm done, I draw the line. This is possible. It takes only to do 9, 10, 11 blood drawing over many days, but then I describe the line. This is very precise. But if I put myself in the situation where I was before, how can I get which patient is which on this slide? Well, I can draw a sample here at about, say, 24 hours, and another sample somewhere else, one here, for example, and then those two samples together will help me understanding which path that patient is following. I need a lot of information about how frequent these different profiles are, how they are associated with age, with maybe von Willebrand level, blood group, specific concentrate. But once I know the average disposal in a population, with a couple of samples, I can guess which path each patient is following. And this is exactly what we do with population pharmacokinetics. Up here, this is a line drawn by measuring many samples. Then I can say, okay, I can't draw all of them. I just take 3 points. And I still draw my line, but you see this dashed blue line, they start opening up. In this one down here, I have only measured once, and you see, it can be anywhere. The average is this one, but it can be up here or down there. The more point I draw, the more this line will get closer, the more safe I am in making the assumption. But I can start making assumption with 2 points. If you look here, 2 points only, I have already a very good idea of when that patient will be at different concentration. If I'm interested in the late phase, I take point in the late phase, and I have very high centrality down here, I'm more unsure up here. Vice versa, if I'm interested in this central phase, I take my point in this central phase, and I can be able to tell this patient when it's safe to play tennis or golf. Here, I can guess better when I'm going to reinfuse him. But in general, 2 or 3 samples, I get a very, very close estimate of the threshold. Is that all I need? Of course not. I need to know what threshold is safe. And I don't want to waste too much of your time this evening. I'm showing you this article that we published earlier this year, putting together a lot of international experts. You recognize for sure Victor, that's myself. This is a statistician in my unit, and then you see representative from France, Germany, UK, the Netherlands, and Belgium, US, and so on. We convened together and we did a very complex exercise to try to find what are the target threshold to recommend for different situations. For kids who never bled, for teenagers willing to do intense physical activity, for those having target joint, and what to do when one concentration fails. The best would be to measure for each patient what the concentration was when he had a bleed and use that as a guide, which is something we will try to do in Canada over the next few years. I'm coming back on this in a second. The other way we are trying to help getting tailored prophylaxis is this paper. This is yet to be published, but this is a statement. Again, you see myself, Victor, Peter Collins from UK, Kathleen Fisher from the Netherlands, the States, Czech Republic. We had convened a large group of hemophilia treaters, and we have agreed on how to perform PK assessment in practice. We have spent time in giving recommendation about is a washout needed or not, what are the optimal time points, and how you do your estimation on the data. And this is because we really believe that we need to do education, and we need to make it easier and simpler to have the PK profile measured. And that's the component about the PK profile. Then we have other components that we are all doing in Canada. So I hope I will be able to convince you over this talk that yes, tailored prophylaxis is important and is a simple concept if you take it at face value, but it requires a lot of data to be done properly. And in Canada, altogether, CHS and ACDC, doctors and patients, we are trying to collect all what is needed. These 4 research programs are active out of McMaster, but are being practiced in all Canada. Most of Canadian centers adhere to, and you can get to be part of them and also to get the fruit of them in any of the Canadian centers. This is WOPS, is what we have created to make pharmacokinetics possible at the point of care. This is the Canadian Hemophilia Registry. If you want to have information about adherence, about when bleed happen, and ideally to connect bleeds and the frequency of treatment with pharmacokinetics, you need to collect this data. And already 16 of the Canadian centers are collecting data through CBDR, RCTC, and very, very good quality data that we hope to be able to use to make case example and convince that is a bit of time you invest for your own interest and for the interest of the community. CHESS, this is the first research program I have activated after moving to Canada, is a standardized collection of adverse effects. To be sure that treatment is tailored, we should see the number of adverse events go lower and lower and lower with time. Because if treatment is ideal, you should have many, many less adverse effects. To be able to show that they decrease, you need to measure them. And we have started in 2012 to have a standardized collection of inhibitor development, thrombosis, death, cancer, all the complications that going forward with the new treatment that will be introduced might become important flags of potential safety issue. There's no way of collecting data on new treatment if you have not done a good job in collecting data in standard treatment. Down here, probe. I don't know if you have heard of probe before. Probe is a patient-reported outcome, burden, and experience, is collecting life goals, quality of life, impact on daily living activities of hemophilia. The program is, the PI of the project is Mark Skinner, so this is based out of UK, but David Page and myself, and also Chatri, Chai, Elisakopa in my unit, are active part in this project, and the database and the data collection website is again at McMaster. You need to measure quality of life, satisfaction, goal attained in education and physical activity to do in a scientific and evidence-based way tailored treatment. So CBDR, I'll spend 1 or 2 minutes on each of the program to show you where we are, and then I'll close on a few concepts on tailoring again, and then we open this for discussion. CBDR, you see the red pin. These are all centers that are already active. In blue, you see where we were 1 year ago. If you consider 0 to 100, the activation process, where 100 is a fully active center and 0 is I'm still thinking about it. 1 year ago, we were at this blue line. Now, May of this year, you see that many centers had been fully active, 16 of them, and you see them depicted in red. Others are very close to be up and running. A small minority is still facing some difficulties in starting to use CBDR, but it's taking on, and we get a flurry of data coming in. We are sure we'll be able to use them to fill out that complex picture I showed you a few minutes ago, where I was trying to say all of these come together, including adherence, including how you collect your information. This is the WOPSIMO. This is the tool we have created to make it possible to estimate the PK profile out of 2 or 3 samples. Is a website where hemophilia treater can go, register their patient, put in the data, and get immediately the PK profile and also treatment suggestion. You see that we are covering most of North America, a good part of South America, all of Europe, China, Australia, Japan, South Africa, and centers are continuously growing. We have now about 100 centers. The good news is that for Canada, WOPSIMO will be in a couple of weeks connected directly to CBDR, and we will be able to request profiles from within our main system, receive result back. We have done already this integration in Czech Republic, in US with Athens, not yet used, but tested and validated. We are almost done with UK. Is a service we provide for everyone. We have thought of this for Canadian patients, but we believe strongly in sharing data, sharing tools and facilities, and we have opened it up to the entire world. This is PROBE. PROBE is a study at this stage, so it's registered on clinicaltrial.gov, and if you go there, you can find what it is in detail, but it's a survey, and I'd like to show you a couple more details, because I think this is something that Canadian patients will be called to contribute to in the next few months. You go to a website like this and you say that you are Canadian, which language you like to speak, can be English, can be French, or can be whatever language your language is. We have over 30 languages available, and you begin to fill the survey. It takes 8-10 minutes. It's very, very quick, and is anonymous. So unless you will decide to tell us who you are, this system will not require you to tell. It just will create for you an anonymous code like that will let you go back to your questionnaire if you want, but for us will be completely anonymous. I'm showing you this page where the code is more because I want to show you that PROBE in Canada is supported by you guys, by the Canadian Hemophilia Society. In each country, when you get to this page, you will see your own local patient organization. This to me is the strength of this project. This is a project where the main actors, the investigators, the one doing the research are patients. Mark Skinner, David Page, Randy Curtis, Brian O'Mahony, Declan Noon, I hope I've not forgot anyone, is mostly a group of patients setting this up for their peers. Then, of course, we support them with the technology and with the expertise in setting up questionnaires, but is a patient-driven project. And these are the area that probe covers. A bit of personal question. We need to know something about which hemophilia, how it's treated. We collect information about which factor, how often, what amount, what the problems are in terms of pain, limitation in physical activity. Very simple question. Have you used crutches over the last 12 months? Did you have problem in, and then you see a list of daily simple activities. Health goals. Do you have any comorbidities, any other disease? And then you submit. This navigation panel helps you seeing what you are working on, what is optional, what is mandatory. We have collected over 2,000 of these around the world, and the average time to completion of the questionnaire, if you do it online, is less than 10 minutes. If you do it on paper, can even be less, but then we have to transfer the information from paper to the database, and that takes money and time. So we really would like you to do it online. Now, this I think is my final or pre-final slide. And I'd like to then open the discussion, but tailored treatment to me means putting the patient in center and front. And what is the objective of tailoring treatment is quality of life, life goals, maybe even convenience. Less infusion, if we can save some, or higher trough, if that's what your life goals and your level of activity requires. But the goal of tailoring treatment is to be sure the treatment fulfills the need of the patient. Then, of course, as a doctor, I like to have some clinical goals reached. I like to have fewer bleeds, as little as possible. And I also like to make a treatment that my patient can adhere to. I try to make a proposal that is feasible. There's no point in me asking for everyday infusion if that patient can't do every day. We have to agree on something that works in a way that I can get my patient to do well, and the patient can get to realize their goals. And of course, if we can do that, also saving some dollars, and sometimes it's possible because the variability is so large patient to patient that for a few patients that you treat less than you should, there are some that you treat more than you should. And if you stop doing that, you may save some money without giving up quality of life, without giving up goals, without giving up clinical goals or adherence. And that's maybe a goal for the society. Altogether, if we try to make for each one the combination of dose and frequency of infusion that prevents at maximum the number of bleed using the minimum amount of factor, we can make treatment for hemophilia more sustainable and maybe easier to access in Canada, but also in other settings where it might be less easy to have access to factor. 3 papers have been published over the last 2 years. Week, which is much less than we use in Canada. You can cut the bleed 20 times and in nodules by times. There's a lot we are learning after we have abandoned the idea that treatment for hemophilia is the same amount given to everyone 3 times per week. And here I'll stop, I'll put back the camera and open it for discussion. assuming there is still someone on the call that I've not killed. First of all, to start the discussion, was there any different concept about tailored prophylaxis? What I talked about is what you thought tailored prophylaxis is, or you were expecting something different? Because that's my concept of tailored prophylaxis. That's what I usually discuss in this field, but maybe there are other ways of thinking of what tailored prophylaxis is.
Well, I was thinking of something different, and I found the slide with the yellow and the green very helpful. So to be able to think of it as two different patients or two different products. Because so I guess what I hear that prophylaxis is so many units per kilogram, and that's your prophylaxis. And then during review, then, well, you missed a few infusions, or you didn't follow. So I think that's where I kind of look at the tailored. I expected the feedback to also be tailored to the patient.
You are right, and I think that this speaks to tailored prophylaxis being much more demanding, not only and not mostly for the patient, but more so for the treater and for the pair of treater and patient. Tailored prophylaxis means we sit together and we identify what we want as a goal. Is easier to say, okay, treatment is the same for everyone. 25 units per kg, 3 times per week. You don't need to waste time. You may not even need to see your patient. That's what everyone does. Tailoring prophylaxis is not, okay, let's do 2 samples, see what your half-life is, and then for you, you need 25, but not every other day, maybe every 3 days, or to stay above 1%, you can take 17 units every other day. That's not tailored prophylaxis. That's just a way of calculating the dose needed to stay above 1%. That's only a part of the game. The other part is, what's your goal? You want to be physically active. You want to play hockey. You want to, instead, you want to just infuse as little as you can. And then once the goal is known, then we have to say, okay, to get to that, we have to look for what's the best way to reduce the number of infusions, or what's the best way to ensure you get on the Tuesday and Fridays, which is when you play hockey, or when you train for whatever activity you do, you get on those 2 days the amount you need. And then that's planning. Then it's like any project in life. You sit, you agree on what the goal is, you make a plan, then you record the information, and that's time that you are right, the patient has to take, but then the doctor has to look at that information. No point for me to ask my patient to collect a diary if I don't sit with them and say, well, okay, this is the plan we made, this is how you implemented it, this is the result. You bled, you didn't, you did your activity, you did not, and is there any correlation between the bleed you had and what you did? And we learn together, and then really every time, every clinical review is a step forward to improve the way we treat. And it's tough, it requires time. You can't do this in 10 minutes visit. It may take half an hour, it may take more, and it may take some preparation before. So I hope this was somehow slept in my message, but tailored prophylaxis is time consuming, is demanding.
Okay. Now, it's my understanding that the centers across Canada are going through the process to be part of the, I hope I get it right, the WAP, is it WAP?
Yeah.
Yeah.
So yes, we have 11 centers in Canada who are already using WOP. PK file has been generated for 232 Canadian patients. It's not a lot if you think that there are over 1,500 severe patients, but is much more than nothing. And for those 232, about 350 PK has been done. So they've been studied on different products, or the study has been redone, which to me speaks to there is someone generating the data and looking at the data. We are planning to collect this information and make a publication out of it, sort of trying to make it more evident to the others what can be done. And this was done without specific funds and without specific support, just making the WOPs available and spending some time like this evening in telling how it is, answering on email when there are doubts. But yes, Canada is
Seems like we're having a little bit of difficulty. We're having a little bit of difficulty with the connection. Are you back? I'm back. Are you back?
Hi.
Hi.
Yes, that's correct.
Okay, so the concept is that the relationship between one bleed and the following one is more complicated than we thought. There are some basic concepts. So a patient who bleeds, who have little, who bleed very little, they tend to bleed less than others. So for reasons that we don't know completely, there are patients with the same level, some bleed more and some bleed less. And that's one point. The second point is that the more you proceed in life, the less you bleed. And again, we don't know exactly why that happened. One reason can be that we are crazily more active when we are young, and then while growing older, going to school and then going to higher school or going to work, we, even if we do a physical work, we tend to do repetitive actions, and we don't have that crazy activity we have as kids. Also, the muscle becomes stronger and they work more than the joint do. So another observation is you bleed more as a child, and we always use this concept in clinic, saying, oh yeah, you are bleeding a lot, but hold on, be faithful, with time we will be able to have you bleeding less. Well, it's not because we are magicians. We know that in life that usually happens. On the other hand, we know that while you build more damage in your joint and you have a higher number of bleed per year, then your trajectory is flatter. So someone bleeding less, with time, he will bleed less and less and less. Someone bleeding more, yes, he will bleed slightly less, but will continue to be observing more damage. Same is for the joint to a point, because at some point then you see a change in direction. When the joint doesn't work anymore, you have still pain. So bleed and pain have to be kept separate. And that's what, for example, probe is trying to show. Not necessarily pain comes from a bleed. Pain can come, yes, I mean, it's always coming from bleed, but pain can be the consequence of bleeding you had when you were a teen. And now you don't bleed anymore in the joint, but you continue to have pain. That's the chronic pain that is associated with many situations in hemophilia. That's what we really want to try to prevent, knowing that once the damage is done, it's very difficult to take it away and will be there to make your risk of bleeding much, much higher. So maybe I was unclear, and maybe I'm still unclear, but it's fascinating to try to connect all the dots where previous bleeds and damage that is done make it more likely for a subsequent bleed to happen, which not necessarily mean you have to treat more intensively. Maybe you need something different. We are now trying to see if just increasing the threshold will make a difference. Maybe you need to act with some other process, which is still part of personalized treatment on what's going on within that joint.
Thank you.
Welcome.
Anyone else with any questions for Dr. Iorio? I guess I have one more, simply because I've been looking at the centers across Ontario, and that is for doing the testing, how important is it the lab and the quality of the lab that provides the test results?
So it is important, of course. I tend to say that PK is a different way of looking at the data we have. So if I have a bad lab, it's not bad only for PK. It's bad when I have a patient going for surgery. If I can trust that result, I'm putting that patient at danger if I send him for surgery. Or if I'm using only TRAF, if I only measuring the level of factor before the following infusion, I will not be sure if that patient is really still covered or not if my lab doesn't work. So whenever someone asks me, but if my lab is not good enough, can I do PK? Well, my answer is sure. PK actually will help you because it doesn't look at one measurement at a time, puts all the measurement together, and so it's sort of average across errors, and is safer to look at a profile where the lab is weaker as compared to look at individual values. The different points are used all together. But the real problem where the lab is weak is that hemophilia care will be weak there, no matter if you use PK or not, because you will not be able to tell for someone bleeding if he has an inhibitor, how high that is. And if you have the chance of measuring factor level around an event, before or after surgery, or after treating a bleed, and you can't trust the result, or you are not sure how much they are variable, you are providing suboptimal care. So if you have a bad lab, the solution is not doing PK. The solution is changing your lab or fighting to have it working. While you wait to be there, PK is helping smoothing off the error. So yes, a bad lab impact on PK, but it's not a good reason not to use PK.
Okay, thank you.
And the same is, can I do with 2 samples? Can I do with in my clinic, I can only draw 1 hour and 4 hours. Then the patient leaves back, he has to travel 6 hours back home. Well, the guideline we are writing with the society, the international society, says that the ideal is 4 hours, 24 and 48, which is only 3 samples, but over 3 days. So some patients say, I can't be in clinic on day 1, day 2, and day 3. First of all, with PopPK, you can say, well, okay, we'll build your profile in 3 years. You come here once per year. This year, I'll give you a shot and I'll draw the 4-hour and then you go. Next year, you inject yourself before the visit. And when you come here, I draw a 24. The following year, you inject yourself 2 days before the visit. And when you come here, I draw the 48. It has taken 3 years. It has taken a bit of organization. But after 3 years, I have the 3 points I need and I do a PK. Now, that may be complicated. And one may say, no, I only want to use 4 and 24. It's better than nothing. And we are now almost ready to publish a study. Even the worst PK, far better than a doctor just guessing. If you only guess, if you don't make the measurement, if you don't take 2 points and you guess, you have a much higher chance of shooting in the dark and killing someone instead than getting a number that maybe not is the best. We have to manage with some other mechanism.
Is there anyone else with any other question? Well, I think not hearing any other additional questions or seeing any in our chat screen, I'll say thank you, and you can look forward to this presentation being posted shortly. Excuse me.
Sources, the lab we have, your chance and possibilities of being here. Let's make sure we don't miss any single opportunity to provide everyone with the best treatment. That's tailored prophylaxis. If you think of it that way, I dare anyone not willing to do tailored prophylaxis and saying we can't, we don't have resources. It's okay, I take it, but really it's difficult for me to imagine that you don't have resources to try to shape treatment of your patient around their needs. What are we here for?
Are there any other questions? Well, Dr. Iorio, thank you very much. I found it certainly informative. For those of you that are interested, the session has been recorded and will be posted on the YouTube channel, and the information will be shared shortly with you before the end of the week. Thanks for joining us this evening, and thank you.
Thanks, Matt. Thanks, Dr. Iorio.
Bye, everyone.